Addressing Youth Mental Health Access Barriers, a Systems Analysis of Headspace in Australia. Framing and Context. The provision of access to youth mental health services remains an ongoing and growing concern in Australia. The 16 to 25-year-old age group is experiencing increasingly poor levels of psychological well-being. However, the mental health care sector remains an ongoing concern in meeting this demand. Issues of long waitlist times, lack of coherent delivery, and reliance upon crisis prevention engagements mean that youth seem to only seek early support when their poor mental health has reached critical levels. In response to the access issue, the Australian government launched the Headspace initiative. The presence of youth poor mental health is a concern across the global world of disease everywhere, and its presence in Australia occurs due to the poor delivery of services. It directly ties in with the UN's Sustainable Development Goal 3, focusing on good health and well-being, with specific emphasis on Target 3.4, which aims to reduce mortality from non-communicable diseases by 1/3 and improve mental health. This presentation critically assesses how Headspace addresses inaccessibility and examines the systemic constraints that hinder the program's efficiency within the complex landscape of psychological health. Policy rationale and intended function of Headspace. The government launched Headspace to address gaps in youth mental health services. The service model marks a marked transition from hospital-based, adult-specific care to youth-specific, community-based care. Headspace centers aim to reduce stigma, promote early intervention, and provide both physical and social support to the individuals they serve. Headspace applies a cost-effective, free service delivery approach to reduce the traditional barriers to help-seeking behavior among the targeted groups. From a policy perspective, policymakers intend Headspace to function as an entry point to the mental health system, reducing reliance on emergency departments and acute services. Strengths and positive impacts. Evidence suggests that Headspace has achieved several important successes. Assessments have revealed that it has improved its service provision and engagement with younger groups of people who might have avoided accessing formal mental health care. Its youth-focused design with an early intervention emphasis has been connected to reduced stigma and improvements in attitudes towards seeking help, especially among young persons with mild to moderate concerns. Research also suggests that Headspace has improved coordination between services by co-locating supports that would otherwise operate in isolation. These strengths indicate that Headspace meaningfully addresses specific access barriers at the point of initial engagement, particularly for young people seeking early support. Critical limitations and capacity constraints. Despite these strengths, Headspace has significant limitations that undermine its overall effectiveness. The demand for services provided by Headspace has far exceeded its capacity, resulting in protracted waiting lists that negate its early intervention role. Staffing gaps, especially in remote areas, also limit service delivery. Moreover, Headspace mainly focuses on young people with mild to moderate presentations, hence referring more young people with complex or acute presentations to public mental health services, which are already overstretched. This has resulted in a system bottleneck, whereby early intervention services consume demand without providing adequate capacity for escalation when needed. Hence, hurdles to accessing services remain despite the availability of a nationally recognized service. Wicked problem and systems analysis. From a systems perspective, Headspace serves as a pertinent example of the difficulties inherent in addressing a wicked problem. There is no singular agreed measure of success for youth mental health services, with varied system priorities between prevention, treatment, and crisis response. While Headspace clearly aims to strengthen prevention and early intervention, the broader system continues to prioritize crisis-driven care due to funding structures and service shortages. Partial interventions can thus shift rather than resolve systemic pressure. For instance, diverting young people from emergency departments may reduce hospital burden, but simultaneously increase workload and burnout in community-based services. These trade-offs are reminiscent of how improvements in one part of the system may generate pervasive, sometimes counterintuitive consequences elsewhere, reinforcing fragmentation rather than integration. Structural and policy constraints. These challenges speak to the types of systemic constraints inherent in the Australian mental health system and not any failures within Headspace as an initiative. A lack of adequate funding for the public sector, restrictions in Medicare rebates, and the cost of living could impact not only the capabilities of services, but more so the long-term viability of the staff. Indeed, without changing these upstream influences, initiatives such as Headspace must function in an environment that is responsive rather than preventative. Concluding evaluation. In conclusion, Headspace represents an important and well-intentioned response to barriers to youth mental health access in Australia. It has improved engagement, reduced stigma, and expanded early intervention opportunities for many young people. However, its effectiveness is limited by capacity constraints, workforce shortages, and systemic fragmentation. As a response to a wicked problem, Headspace can mitigate specific pressures. However, it cannot resolve underlying structural drivers in isolation. Addressing youth mental health access therefore requires coordination, system-wide reform that aligns prevention, treatment, and crisis response across the mental health continuum.